good afternoon. Thanks so much for joining us today. I'm really excited to be here. We'll talk about neural consideration in climbing injuries. It's a topic that I think is extra important, and I'm super excited that you're all sharing that with me. Just a bit about me before we start. Like Jared said, I'm a physio in Cape Town, and then I also spend a lot of my time in Rocklands, bouldering. I did my undergrad in Austria and then my Masters of Exercise and Sport Physio at the University of Cape Town. And I'm quite involved here lecturing and a part of the ANMS course as well. So yeah, without further ado, before we start, a big shout out to the Advanced Neuromusculoskeletal group, or the course, the Western Cape group. They're amazing people. They've taught me everything I know. So I just wanted to mention that here. They're formerly known as OMT. And for those of you who haven't got any travel plans, there is a congress coming up in April here in Cape Town, the International OMT Congress. So yeah. Before we go on, the NMS is really a really good little brain snack when it comes to clinical reasoning. So we always say when we hypothesize, if we look at the area that our patient has symptoms, we really should come up with a clinical reasoning hypothesis for the underlying nerve that could refer to that area, the muscle that could refer to it, and the skeletal structure. And if we do that, we're already on a really good path to make sure we don't underestimate or we don't forget about a potential neural involvement in our symptoms. Yeah, sorry, I've got a bit of a cold. I might be sounding a bit froggy. Okay, as these things go, we always have to make sure we're on the same page. So we're going to start with a bit of terminology. This is one of those topics that is quite difficult to really collect your evidence and to get a good understanding of the literature because everyone has a different term for it. So the terms I'm using today are based on the NMS group's definitions. We're going to be talking about peripheral neuropathic pain, nociceptive neural pain, and that's actually going to be mainly the focus. And then you shouldn't forget about neurogenic inflammation, although that is a topic I'm going to reserve for later in the year because it's more of an advanced consideration. But yeah, I do think that plays quite a big role in some of our, especially finger patients, I find recently. So peripheral neuropathic pain, this is our good old, this is looking for a lesion. You've got your classic conduction signs. Everything fits together in the neuroanatomical appropriate area. You've got your sensation, your muscle power, your reflexes that all come up with a very clear picture. We've got a very nice standardized questionnaire for that. That's the DN4. It's just 4 questions, mainly about the quality of pain, and then also 2 about your physical findings. And if you have those, it's got quite a strong, it's validated quite strongly. Then Finnerup et al. 2016, they've defined it a bit better for us, or in more depth. And they said, if you listen to your patient, it sounds like you've got that distribution, you've got all of your, it just sounds like this, then we can speak about possible neuropathic pain. And once we've done our physical examination, you've got your conduction findings, everything comes to a coherent picture, we've got probable neuropathic pain. And as physios, we can never have definite neuropathic pain, at least in my country, because we can't send for MRIs and nerve conduction. So in their definition, you can only have definite neuropathic pain if you have the actual diagnostic tool that's confirming your clinical diagnosis. Okay, before the peripheral neuropathic pain, in my experience, that is what the surgeons are really good at. That's, I don't want to step on any toes here, but in my experience, that is where their understanding of nerve involvement is really rooted in. So when I refer with a more complex or a more vague mechanical issue, I often get the response, no, we're fine because this and this is fine. So yeah, that's just a bit of the understanding I had. And then also don't forget that central neuropathic pain is the pain that originates from MS or strokes or spinal cord. So peripheral neuropathic pain, really anything that comes from the nerve roots outwards. Okay, then that brings us to nociceptive neural pain. So this is my, I love it. Nociceptive, it is a signal that comes from nociception in the periphery, gets sent to the brain interprets it. What we have to remember, or what we have to understand, is that our nerves are actually innervated by the nervi nervorum, and they're attached into the nerve sheet. And those are mechanical sensitive to anything that really affects their blood flow. So traction or compression. So nociceptive neural pain means somewhere along the line, the nerve doesn't get its blood flow. I always tell my patients nerves are bloodthirsty. They seem to understand that quite well. So yeah, anything that affects the blood flow, the nerve says, hey, what's going on? And it starts giving us weird symptoms. Other terms in the literature for this is peripheral nerve or neural sensitization, or mechanical peripheral neural sensitivity. So yeah, this is quite important that we grasp this, because this is at the heart of our diagnostics. Okay, so now talking about the anatomy, that will clarify it a little bit more. And if you look about the nerve system, don't worry, I'm not going to go into axons and synapses and all those little nuances too much, but more into a whole. If you look at the nervous system, it really is one big fishing net of a system. So your little toe is connected to your thumb. Everything is connected. But I have an analogy that I'll actually use with my climbing patients, and it works really well. So if you look at the brachial plexus, the nervous system that goes into our arm, it really behaves like a sport rope. The nerve goes up the one side, goes through your chains, and down the other side. Okay, and they seem to understand that quite well. So more classic understanding is your nerve goes up and then to the brain, but because the nervous system is so closely linked, it really does behave more like a sports rope. And like any sports rope, you can have rope drag. So in our chains, if our chains are stiff, you can imagine you've got more rope drag. And what other thing contributes to rope drag? Quick draws. Okay, so we've got all these quick draws of muscles where the nerve has to go through, that if those are tight, we're already increasing rope drag. Increased rope drag, less blood flow, funky symptoms. Okay, so looking at our chains, it really all starts at C2. C2 is crucial when we think about the mechanics of the nervous system, because the dura mater really extends down to C2. And as you see here, we've got all these wonderful short muscles that attach to C2. And we've got very high level evidence of, oh God, I have to say that name, Palomek del Cameron of 2017. They had a systematic review, and they've established that these short extensors all have soft tissue connections into the dura. So if these have very high tone, they already affect how much the dura and therefore the nervous system can move. Or if C2 is under stretch the whole time, like we said, compression or traction, that would also affect the mechanics of the nervous system. So with your diffuse neural symptoms, having a look at C2, assessing what's happening up there is crucial and really, really helpful. It also explains why headaches often go with us, and dizziness and all those, the trigeminal nerve area. Okay, I've got a little video for you. It's one of those, hope it works, it should. Okay, again, you see our sports rope, it's going up the one side, through the chains, down the other. Now, adding our quick draws. So you'll see the scalenes are a big one. The scalenes, brachial plexus, go through there. Another big one is our pec minor. Our climbers are quite familiar with that one, really tight all the time. Bicep, tricep, we've got that interface over here, medially and also laterally with the brachialis, and then ulnar nerve more on the tricep side of things. Going into our forearm, and again, thinking about your forearm pump and your really tight, big forearm muscles in climbers, you can imagine how the nerve could get into a little bit of trouble there. And of course, the flexor carpi ulnaris, the ulnar nerve has to go right through there. Unfortunately, I didn't extend it quite far enough, because it really does go, the nerve goes right there, along right about where we have our pulley symptoms, their lumbricals. So we'll speak a little bit more about that in a moment. Then we have on the lower limb, the lower quadrant, again, coming up the side, through our chains and down. Now, segmental mobility of the lower back is really, really important for this kind of condition. And I see it so much that people just forget that they're allowed to move their lower back. And again, if you think about chains not moving, that would be a start of some issues here, because of course the femoral plexus is coming from L2 to 4 in the front, and then the sacral plexus coming from L5 S1 and below. Then we've got a psoas and iliacus. That nerve has to go through, big one. In the back, sacral plexus, everyone knows the piriformis, but also consider the hamstring. that nerve really goes smack bam in the middle through the hamstring. So think about your heel hook injuries. And then our proximal tib fib joint, that peroneal nerve comes through there. Again, tight peroneals, quite a common thing, hiking injuries, ankle sprains. But also, if you think about those heel-toe cams, what kind of rotational force and freedom that nerve really needs in those really aggressive heel-toe cams. Okay. Excuse me. Cool. So that's the anatomy. Do we have any questions so far? I'm not hearing anything, so I'm just going to keep going. Yeah, so that brings us straight to the nervous system assessment. And here I'd like to hear from you guys. What is it that your patients report that makes you think, oh, this might be neural? What are the big ones? Does anyone have anything they want to share?
Like a tingling sensation?
Yeah, tingling is a big one.
I will often, sorry, go ahead, Gail. I'll say if I have a patient that comes in with bilateral symptoms that don't necessarily match with like a traumatic injury, I'll quickly go to potentially nervous system, kind of more, closer to the spinal cord than peripheral, but still kind of sets off nervous system for me.
Mm-hmm. Good. Yeah, also talking about red flags, but we'll get to that in a moment. I'll just make a note of that.
In the chat, Evelyn put type in quality of pain, so burning, tingling, and numbness, and Dylan put cold, tingly, pins and needles.
Exactly. Okay, cool. Yeah. So those are all the classic symptoms, right? That's what we get taught. But in my experience, it can also be this achy pain, like very tooth achy, diffuse. You can't really define it really well. It's just weird and achy. Also the symptom onset. It often is latent. It doesn't come straight away. So it can be up to 48 hours later. So that's always a bit of an indication as well. Or something that is incredibly sore for 2-3 days and then is gone. A tendon or a ligament wouldn't behave like that, or a muscle strain. So that's also one of those things. Oh, and then excessive pump. That's one. I wish I had evidence for this, but I definitely see it in my patient population. I don't know if any of you can back me up. They say, I just get so much more pump these days. And yeah, I think that's mainly because of the connection between the ulna and the radius. So we've got a fascial connection. And yeah, I think that's with the nervous system and that neurogenic inflammation that adds into that pump. But if anyone wants to research that, I think that'd be pretty cool. Okay, so I've just mapped out the kind of symptom area that our patients complain of, and it's really anything along the line of where that nerve runs. And if you look at that, forearm, you've got your medial lateral epicondylopathy. So those always make me go, ooh, we need a clear nerve. Your bicep pain, you're like, I just like, every time I climb, I just get this bicep pain. And like you said, the bilateral bicep pain, and then the pump, that makes me really go, oh, we need to look at this. Banded wrist pain is another one of those. But even your finger pain. So you'd be surprised how many of my fingers I actually find a neural component in. So it's quite a good habit to just check your neurodynamics when you're doing a clinical assessment. And the lower limb, again, pretty much anywhere where that nerve runs can give us symptoms. Okay. Then we need to think about our mechanism of injury or the symptom onset. As we spoke earlier, the nervi nervorum respond to traction or compression. So we'll talk a little bit about that as well. And I've already spoken about the timeline. But yeah, that symptoms coming up to 2 days later, or settling quite quickly. So the climbing specific consideration for traction, carrying boulder pads. This is quite a big one, and I'm really, really happy to see that the companies have come out with much better carry systems. But we all know those very fat, big pads that have no waist strap. They're completely pulling on that brachial plexus, pulling backwards, opening that up. So I routinely advise my patients, if you have one of those old pads, mod them, add a waist strap, do a little something small, like just using a bit of string and just tying together the shoulder straps just to offload that brachial plexus, because that can really wreak havoc on our nervous system. And it's not great starting a climbing session with a nervous system that's already shouting for oxygen. The other thing is belaying and extended cervical extension. So belay glasses are great for this. But also just looking up. I mean, if you're at the gym, you're watching your mates, you spend a lot of time in that cervical extension. And again, if you think about that C2 and all those short extensors, it's no wonder that that could sensitize our nervous system too. Also, if you think about the other extreme of everyone being on their phone on complete stretch for the rest of the time. So we've got both extremes there. Dry firing. Dry firing is a big one that can really flare the nerves into the finger, in my experience. Again, some of this is just not evidence-based because there is no evidence out there, unless you've got some. If any of you have any papers to share, please do. Then dinos without properly stabilizing the arm and the shoulder. You can imagine this like classic jumping for it and just full on that, nearly subluxing your shoulder. You can imagine shock loading that brachial plexus, and that would definitely affect the nervous system and the blood flow. Same as foot pops. So those are just some of those traction conditions. And then compression. Compression, if you think about the quick draws, I think it makes a lot of sense. Interface, muscle tone, or shortening. So pec minor, actually all the classic, right? Bicep, forearm flexors, our good old T-Rex climbing posture predisposes us to a bit of neurodynamic issues. Our posture of that anterior depressed shoulder girdle, especially the depression, I find with climbers, because we're so strong in the pulling muscles, our shoulder girdle already sits in such a depressed condition. And with that, the nerve going through the collarbone already has a bit of that compression there, or you could also call it traction, I guess. And then people still overset, and it's like, oh, but I need to be so good about my shoulder, my scap, and really pull it down. And if the nervous system is already a bit sensitized, that can then be the what do you call it, the stick that breaks the camel's back. Cool. Once we've kind of got an understanding of the mechanism, we go straight to our physical evaluation. And here the active range of motion is really just so useful. I'm always surprised how much you can find of just a quick checking, flexion, extension, rotation, side flexion, and always just try and put into context, right? So if I've got right-sided symptoms, now my symptom gets worse with right-sided side flexion. Okay, so now that's more of a compression on that side. So I'm closing the joints. So now I'm thinking more spinal nerve root. If I go, side flexion to the contralateral side increases it. So now that's more of a traction thing, brachial plexus, or the nerve root can have a traction component to that as well. Cervical flexion going all the way into thoracic spine, that kind of tension, or even into the lumbar spine, can give us a lot of indication of neural tension already. General thoracic mobility, extremely important, always important to assess. And I mean, we know our climbers, we stiff into cervical thoracic flexion, that segmental extension is lost. And if you think about the autonomic nervous system running along the thoracic spine, it really is quite crucial that we maintain good mobility of the thoracic spine so that we can regulate our nervous system better. But that's a whole other topic into itself. Lumbar spine, a good old forward bend, right? Just having them do a forward bend. First of all, you see that segmental flexion, which gives us a lot of indication. And then they have that tension in the hamstring or even into the calf. And then what I tend to do, I just keep them into that flexion and I just move the head and I see if something changes. And if something changes, and I haven't changed anything to the hamstring, so whatever's happening there is definitely got a neural component to it. Then testing conduction and neurodynamics, really, really important. We'll talk about conduction and neurodynamics in a separate slide in a moment. Palpation of interface muscles. You can palpate nerves. Be careful though. I've got one horror story of a physio poking around and really searching for the spot and going in there and actually causing neuropraxia. So nerve palpation is not something that I routinely do, but I do know that it is part of the battery of tests for neural evaluation. And then the special tests, I forgot what they called them. The OTs are really good at watching that. The seeing if you can grasp a paper and stop that from going. And then the carpal tunnel test. If any of you remember the name of that, please pop it in the chat. So the special tests. But in my
what?
Yeah.
Is it reverse Fallon's?
Yes, that's the one. Thank you.
Okay.
Awesome. And you remember this one as well?
I don't, sorry.
Okay, no, yes, thanks though. Yeah, I think it's an ulnar nerve test. But yeah, in my clinical practice, I don't actually make it to the special tests. I usually find that with the conduction and neurodynamics testing, I get a fairly good idea of what's going on. And then I already have enough retest parameters to see that I am making a difference. So yeah, excuse me. For the conduction testing, we already spoke about it earlier. We need dermatome myotome reflexes. Just to remember, conduction, we're looking at probable neuropathic pain if we have clear findings. If we have very diffuse findings, like a bit of sensation there, a bit of sensation changes there, it's not quite numb, but it's just a little bit different. Muscle power is not, it's like just a little bit reduced. Then it's more indicative of nociceptive neural pain and a mechanical issue of the nervous system. You have a question? No, okay, cool. So dermatome, I didn't include the table on purpose because this is something we need to know, right? C5, C6, C7. We need to just run through these, make sure that you do them every day in your clinical practice, especially as first-line practitioners. Dermatome, myotome, you need to have that waxed. You need to just be able to, within 5 minutes, run a quick conduction testing because it really is an important screening tool. In terms of the dermatome, we test light touch, we test pinprick, and then if you really suspect it but you can't quite find it, the newer tests are the QST, where you test pinprick all around the limb. It's also pain to pressure and temperature changes, but that's more nuanced. In reality, in my practice, I usually just do light touch and sometimes a pinprick. Okay. For neurodynamics, now this is where it becomes really important. In neurodynamics, they tell us about our nociceptive neural pain. It's so useful. So you can already in an active movement say, okay, I'm feeling my pain in a gaston. Okay, so go into the gaston. You're feeling your elbow here. Okay, does it change if you move your neck? Oh, it's better. Okay, so I've already got an indication that there might be a neural or cervical component. We've got our upper limb tension test, and we'll talk about those in the next slide. The slump and the straight leg raise. The straight leg raise is really handy. We can differentiate PIP, SID, and TED. Don't know if you guys are familiar with those. The peroneal nerve with the inversion plantar flexion, the sural nerve inversion dorsiflexion, and the tibial nerve with the eversion dorsiflexion. Now, what's really important with the neurodynamics test is that they're done well. Okay, so whatever element you're adding, it has to be maintained before you add the next element. You have to make sure to ask your patient about symptoms every step of the way. Always make sure that you start on the non-affected side to get your baseline. And also make sure that you don't scare your patient. There's actually been one study out, and unfortunately I don't have the reference. They've looked at how it changes if you tell the patient that it's nerve that you're testing. So I tend to tell my patient, I don't tell them that I'm testing the nervous system. I say, I just want to see how things are moving into the arm. So I'm just going to do a battery of tests. I'm just going to get you moving and see what kind of symptoms we get. And afterwards, I explain to them what I just did. Okay. So in neurodynamics, we are looking for the patient's symptom. That is what the test is there for. I have shared a video with Jared. But please, if you look at that video, take some notes because there's a few things that I wasn't too happy about. So they say, yes, we are looking at a marked difference or range of motion, but we're looking for the patient symptom, right? And then in the video, they go out of it and then add a stretch and see if they can re-elicit the symptom. I prefer to just stay in so like if I go into a medium upper limb tension test, median nerve, it's like, okay, so this is where are you feeling your wrist? Okay, so if you're feeling your wrist, I'm changing your neck. Okay, now it's better. Okay, I haven't changed anything in the wrist or the forearm. Therefore, I can be certain my change was the nervous system. It's a really handy educational tool for your patients because it clicks for them. It's like, oh, you didn't actually change the muscle length. I was convinced this was muscle, but you didn't change my muscle. And my pain was gone. So you can actually see that aha moment in your patients. If they're feeling in the shoulder, then you remove the wrist element. Like, oh, that is better. The same thing with the hamstring and the ankle. If they feel it in the ankle, you change it at the hip with the straight leg raise. My personal preference in those dynamic tests is that I reduce tension to differentiate rather than increasing it. I'm careful with these because you can also, if you tend to practice these with your colleagues, please be gentle with each other. I've left many a practice session with a headache from just neurodynamics being tested over and over again. The nervous system is quite quick to respond to that. And also don't just hold them in that position all the time. If you find yourself talking, go out of the position, rather go back into it. But don't hold that nervous system on traction. Always thinking about nerves are bloodthirsty. The moment we start pulling on them, we take their blood flow away. It's very much like a climbing rope, right? If you pull on your climbing rope, it gets thinner. Thinner means less blood flow. It's another image that resonates quite well with our climbing patients. Okay. Common climbers findings in the PE, in the physical evaluation. We already spoke about this, the depressed anti-rotated shoulder girdle. So just having them in neutral, say, okay, let's see. Pulling up, okay, it's quite a lot of range there. Go back to neutral, pulling down, oh, not much range there. So that already gives you a bit of an idea of where they're actually sitting in their neutral. Increased tone and shortening of pec minor, bicep brachialis, brachioradialis, forearm flexors, especially FCU. In climbers, that is, especially underclings, slopers, FCU tends to get quite tight. Ulnar nerve can get quite grumpy going through there. And the lumbrical shift syndrome. I actually just had a patient, this morning, classic lumbrical shift, climbing in a pocket, foot pop, quick shock load of the FDP, complaining of severe numbness in the median and ulnar nerve distribution, just quite acute. So I had to back off, and we'll see how she does. But once I treated her neck, she felt so much better. So lumbrical shift, don't forget to test your neural symptoms. Just don't do it too early because we don't want to put that early healing tissue under stretch. So give it a couple of days for that acute phase to settle. Hip flexor tension in your very steep climbing. You will think about the femoral nerve having going through psoas and iliacus. That can always create some tension there. And then your heel hooking injuries, either really muscle belly hamstring, indirectly through the scarring, or actually directly tension. And then the rotation in the heel toe cams. Okay, any questions so far before we get into treatment? Anyone? No? Okay, cool. So treatment. So first of all, treatment principles. Of course, we always check our intensity according to our SIN findings. I'll speak more about SIN in a moment. Interface releases can work wonders. Again, if you think about that rope drag, if you think about widening a quick draw, that'd be so easy. That can definitely reduce our rope drag. Neuromobilizations, we treat distal from and this is distal from the symptoms. So if you have a finger, I'll start with the neck. So away from the symptom. At first, gliders before tensioners, always being gentle, coaxing that nerve back into movement rather than really pulling on it and taking more blood flow away from it. Gradual return to climbing, a guided return to climbing is really important. And of course, continually retesting your conduction. We're quite surprised how much we can change that muscle power in a tricep with just a little bit of interface release. I always find that really, really cool. Okay. SIN considerations. SIN, just a reminder, severity, intensity, and nature. So those are your, very severe pain, very, very sore. I'm going to be extra, extra gentle. Nature, if I've got those bilateral symptoms and now there is conduction findings, it is something to refer. It is a potential red flag. Your other cord signs, please just refer out early if you do suspect them. Bladder and bowel, never to underestimate. Spastic bladder, needing to urinate more often or struggling to initiate peeing. So those refer out. And also test cord, Babinski, clonus, your plantar reflex and your clonus, just to test and make sure that you do your due diligence. Back to the high SIN patients, they're very acute conditions. We can offload them quite nicely with tape. If we tape the shoulder, we take just a good old strapping of the shoulder, can really take the weight of the plexus, the weight of the arm of the plexus. So just to give a little bit of support and just give the nerve some space there. Rest, ice, good old police protocol. Nerves respond quite nicely to ice, so that can even be an indication in your clinical reasoning. Okay. General interface release. Be gentle. So intervertebral level moves, always nice. Some upslopes, some gentle, whatever's indicated to whatever you find in your physical examination. First rib mobilizations are very, very useful because the scalene is attached on our first rib. So getting that first rib moving already takes the tone out of the scalenes, which then gives space to the brachial plexus right there. Gentle soft tissue techniques. If you do scalene release, try and do it in an offloaded position. Do fascial techniques. That's getting more and more evidence behind it, like skin rolling. It has to do with those free nerve endings. So really releasing that fascia and making sure that everything has space to move can help with the overall mobility of the nervous system. Then we have specific neural mobilizations. I've taken some videos for you that Jared's going to share with you of the cervical transverse glide. It's a Kaltenborn technique. It is super, super useful. You stabilize the scap and then just do a lateral glide or transverse glide of the entire spinal column. Because it's Kaltenborn, you actually go into a bit of resistance. And you'll be surprised on how the tone of the muscles changes. If you just get, the idea is to move the nerve through the spinal column as a whole, and then everything seems to settle down really, really nicely after that.
Do you want me to, Julia, do you want me to show those right now?
I think we can. I think
yeah.
Oh, wait, I can do that.
Okay, great. Yeah, pull those up and you can talk through those as well to put the visual.
Perfect. Yeah, I don't know if I think I shared, let's see, there we go. Oh yeah, wait. Can you guys hear that sound? No,
yes.
Because I said share that. Oh, you can hear it.
The findings, you position your hand either in the mid-cervical or in the lower cervical. To start off, our patient is positioned in a non-neural position with a bolster under the knees and your hands on your tummy, please. There you go. If the left side is affected, my right hand is going under the neck and grabbing the spinal column. Okay. Your left hand is holding the scapula. It's not depressing, but just stabilizing. You go down to be on level with your patient, and the forward direction is a transverse glide. In this technique, you move into resistance, but only gently. You do 8 repetitions, and then you can follow that up with the first rib mobilization in an offloaded position. We can progress this exercise by moving into more neural position, for instance, straightening that elbow. Important is that the elbow is pointing 90 degrees into the treatment plane. There you go. This is the transverse glide.
So that's the one. Any questions about that before we move on?
Yeah, I have a question. For your hand placement on the right hand, is it broad across like all TPs of the right lateral side, or is it like segmental?
Yeah, so thank you, it's a very nice question. Yeah, it's quite a wide grip. So you're really grasping the entire spinal column. And either the medial cervical or the lower cervical, depending on if you think it's more medial nerve or more radial ulnar nerve. But you're really trying to move 3 to 4 levels at once. So it's like an overall broad movement. Cool. Any other questions? Cool. So then I want to show you the opener according to Schaefer. This is a very useful technique for the lumbar spine.
The opener according to Schaefer in combination with a lower lumbar glide. You can either do this technique stabilizing on L2 for the femoral plexus or stabilizing on L4 for the sacral plexus. Your patient is inside lying with the pillow between the knees to be non-neural, hips roughly bent at 50 degrees and knees 70 degrees. You're standing, the treatment side, the affected side is at the top. You place your thumb pushing down on L2 just to stabilize, and your other hand hold onto the ilium, trying to have a comfortable grasp and not too pinchy and grabby. You then use your body weight to effectively do a slight side flexion while stabilizing L2 or L4. We do 8 repetitions of this and then follow it up with a neural glide of the leg, going from knee extension, plantar flexion, to knee flexion, dorsiflexion. You can either start gently with 8 repetitions of this and 5 repetitions of the glide, or do 12 repetitions of the side flexion with 8 of the leg glide. In order to progress this, you can start in a slightly neural position by straightening the top knee. Thanks.
Cool.
So
Questions
I'll
on-
share, and Julia, I'll share those clips as well as the assessment video that you sent to everyone in the follow-up.
Awesome. Yeah, with the assessment video, please just remember the notes. Yeah. Okay, cool. Yeah, so those are 2 very useful techniques. I use them on a daily basis. They're very gentle. They're just getting that nervous system moving. When I do the glide of the opener, I try and stay free of symptoms. So that can be a really small glide, really small range on a very acute patient. But you can go into a very big movement as you progress and as things start settling down. Other useful techniques is a nice AP glide on the glenohumeral joint. Mobilizing the radial head is very powerful as well. Then I like to mobilize the radius versus the ulnar. Supination is key. So a lot of us climbers like really strong in pronation, but the supination gets tighter and tighter and we lose it more and more. So opening up the fascia in the forearm, giving that nerve space to move through the fascia and really making sure that we have that supination. Also lengthening the pronator again can be very useful. Getting the carpal bones moving, and then I didn't add for the lower quadrant psoas releases. I know there's a debate in the literature if we can actually really feel that psoas. I'm convinced we can. Any physio who's ever done the technique, you feel the change in tone. It's the one where you palpate through the abdominals onto psoas and then have the patient do a leg glide. So yeah, releasing psoas is important. Hamstrings, peroneal, tib anterior, and then mobilizing the proximal tib fib joint can be very useful as well. Okay. The main interface muscles, I think we have spoken about those. I mean, I've just listed them again. I don't think we have to go over that again. Gliders versus tensioners. Any thoughts? I've already given it away a little bit, but anyone have any thoughts about when to choose gliders, when to choose tensioners? I know the literature often uses them interchangeably. I strongly disagree.
I mean, you said gliders before tensioners earlier.
Exactly. Thanks for paying attention. Yeah, so it really is. If we think about our whole strategy is to increase blood flow, right? A tensioner, by definition, reduces blood flow to the nerve. Yes, a happy, healthy nervous system can definitely tolerate that, but in my experience, we really need to get that nerve to settle down before we can work into a tensioner. So that, I tend to actually early on in my career, or fairly recently even, I didn't progress into tensioners enough. I was all gliders based. And I do think there comes that point in rehab where we need to go into tensioners. We need to remind the nervous system that it has to tolerate a certain amount of tension. But it just has to be quite well graded and well dosed.
And I just dropped an article in the chat, Kupatir's article on sliders and tensioners that people can check out as well.
Awesome. Thank you. I'm looking forward to reading that. And then something I forgot to include in the slides, but something that is really important to remember is that the state of the nervous system can change really, really quickly. We all, I don't know if I can blame the pharma industry, but we all think of this nerve thing as something big and scary and it's there forever. But in reality, we can make changes very, very quickly. And if we think about strengthening and rehab, an active nervous system, a nervous system that is in the fight-flight mode, will not let you strengthen. It won't let you activate the stabilizers. It won't let you rehab properly. But it doesn't mean that you can't settle down the nervous system within your session and then go into strengthening. So it's always it's a right now. So even prescribing your rehab, starting with some neck mode, some nerve glides before you go into the strengthening stuff can be quite useful. Just because the nerve is active right now doesn't mean 10 minutes from now it will be as active. So it really is, I want to encourage you to think of it as something that can change so well, and you have the power to change it, and how cool that is. And I think if we can get our patients to see that, we can take that big scary nerve factor away and really empower our patients to be more educated about this. Return to climbing. This is where this is what it all comes down to, right? This is why we do this. This is at the heart of most of our patients' desires. And the beauty of our sport is that we can mod it so much that we can return fairly quickly. Liking to include a very specific warm-up. Like I already said, I like to give some like mulligan, self snags, C2, get that cervical, if it's indicated, get that cervical spine moving, or the lower lumbar spine, do some segmental movements, a mobility-based warm-up, getting all those joints moving, adding some glides, activating some stabilizers, and just making sure that you set your patients up for success. When it comes to the actual climbing, decreasing the potential for a foot pop, especially in those early acute days. So good footholds, brushing footholds, making sure your shoes are clean. The condition of your climbing shoes are quite important. So all of those things play a role. Considering the wall angle, I mean, the steeper you go, the more pec involvement you're going to have, the more strain you're going to have on the neck. So starting off on a more vert kind of slabby situation, controlled, small box climbing. I'm just making sure we leave out those very far moves, those very dynamic, explosive moves in the beginning. But by all means, they have to be included into our rehab. We can't climb the small box forever. So as that nerve becomes happier and happier, we definitely have to send that message to the patient that it's safe to go there, giving that self-efficacy and having them trust their own bodies into that again. Dosage. This is tricky because generally I have my 2 out of 10 rule. You can do anything you want up to 5, feeling like a 2 or 3 out of 10. It should settle fairly soon after the session. You shouldn't feel it the next day. Doesn't work with a nerve as well because the symptom onset can be the next day or even 2 days later. So I always say first couple of sessions back, set yourself up for success. Rather have a really short, high quality session, leaving feeling empowered, feeling good, instead of sending yourself in that downward spiral and getting grumpier and grumpier because I can't climb. So rather doing a little bit too little in the beginning and then building from there. So finding what your safe dosage is and then building from there. And then I found that a lot of my patients have their early warning signs, and those are really unique to each case. Some people feel tension build up in their neck. Others is the dorsal shoulder. It's actually something I forgot to mention earlier. The dorsal shoulder is getting more and more attention from the surgeons as well as an important neural interface. So some tension in that posterior shoulder. That bicep, it's just a bit twingy, it's a bit achy, or that little bit of a wrist sign. So just getting your patients tuned into what their experiences are, what their body is telling them if the nerve is getting a bit grumpy, if that blood flow to the nerve is getting a bit reduced. And then how about stretching? What are your thoughts about stretching in this context? Any ideas?
Are you asking about nerve stretching or muscular stretching or what? Or everything?
Exactly. Okay, so you're putting your finger on the problem there. I think stretching, absolutely, but we need to make sure that our patients understand the difference between a neural stretch and a muscular stretch. You get those people with a very sensitized nervous system and they're like, yeah, but I feel it so well when I go into this wonderful arm stretch. And it goes, and and they're just stretching into that brachial plexus. And as a reflex reaction, that pec is tightening more, that bicep is tightening more. So I make a point of educating my patients, like, okay, so where are you feeling your stretch? If you change something away from that area, does the stretch change? And then having them have that aha moment that they're not actually stretching what they're trying to stretch. So whenever we are stretching, make sure that we have intention, we know what we're stretching, why we're stretching it, when we are stretching it. So just be mindful of how to stretch and when to stretch. Cool. And that is me. Any questions?